Welcome to The Right Chamber,
the podcast where we dive deep into the fascinating world of medicine and healthcare.
In every episode, we will talk about pivotal topics relating to medicine and surgery in the UK and what it's like to be a healthcare professional today. We are inviting doctors and other healthcare professionals across different specialties to discuss their experiences and give an insight into what their journey has been like. Please follow us on Instagram and TikTok at RGUCMS and subscribe to our YouTube channel, RGUC Media. So sit back, ignore the traffic, and enjoy the Right Chamber podcast. Dr. Richard Alleyne, a palliative medicine consultant since 2014, primarily serves the community. Over the past 3 years, he's also been a wellbeing champion for resident doctors. His dedication in both roles earned him the prestigious Medical Directors Committed to Excellence Award in 2023. Hello everyone, welcome back to the Right Chamber podcast. I am Victor and with me is
Jaspreet?
And we have got Richard back with us today. So if you followed on from one of our previous episodes where we were talking about well-being, we did promise that we'll have you back and we'll talk a little bit more kind of about the palliative care medicine side of things. But just in case anyone listening perhaps hasn't heard our previous podcast, would you mind just kind of introducing yourself and what you do?
Yeah, so my name's Richard Alleyne. I'm a palliative care consultant. I used to be a GP. Well, I trained as a GP initially and then decided that I did a bit of palliative care during my GP training and then decided that this was for me. And when I sort of tasted palliative care, I was like, yeah, this is what I'm going to do for the rest of my life. So that's what I do.
Wow,
Yeah.
Brilliant. And I guess let's kick it off as to what did you see, or what was the kind of trigger moments during your time as a GP that made you think, actually, it's more palliative care I want to pursue?
Yeah, so not to knock GPs, my wife's a GP. She's a GP partner. I'm seeing the challenges that GPs have. And I think when I was a GP registrar, I just felt like I was completely isolated in this room with 40 patients a day coming to sort this problem out. And I just wasn't, and I'm quite slow and it just wasn't for me. We were always running behind. I just couldn't do it. But as part of my rotation, I did a 4-month placement in a place called Compton Hospice. It used to be called, it's Compton Care now. And during that 4 months, it felt amazing. I don't want to sort of overuse a word like that, but it really was for me like a life-changing experience to be able to have that time to talk to people about what was going on in their lives, to have the time to treat people as in a very holistic way, to be present in what is an absolutely sacred time of life. There's only one, you're only going to die once, and we've got to get it right for patients. So to be part of that is a huge privilege. And there's one patient that stands out to me. It was a patient who was like so different to me. He was a 66-year-old builder. I mean, this is 20 years ago now, but he was a 66-year-old builder. I was in my sort of early mid 20s, I think. And we had nothing in common. He was, making rude jokes. He was very brash and a very sort of cheeky guy, really.
True.
And I'm very different to that. But when someone is vulnerable and they are that poorly, all of those barriers come down. And I was able to connect with this guy in this, what I felt was a very special way. And I just remember feeling like this, to me, feels like real care. Now, don't get me wrong, every specialty is real care, but for me in that moment I was like, this is the type of care I want to do. And then when he died, I was like, I want to continue to have these sort of connections with people and make this sort of difference. So it was that really. So I finished my GP training, applied for palliative care, and in those days, well, it's something like coming up to 20 years ago, those days it was probably a lot easier to get into than it is now. There are only 3 applicants for the job at the time.
Wow.
And 3 jobs, 3 applicants, and somehow I got in. And and so I've been a consultant here in Dudley. I was a registrar here in Dudley, and then I became a consultant here in December 2014, I think.
Well,
So I've been a consultant here for nearly 11 years now.
Obviously, you found your calling once you did
I think so. Yeah.
Yeah, because I assume like in GP you have 10 minutes, so you can't really connect with your patients.
It's different. It's very different. You connect in a different way. But this was, palliative care for me was, because I really love talking to people, finding out about them. It's what I love doing, my well-being stuff. But then not just talking for the sake of it, but exploring issues and finding out what's going on underneath the surface so that we can really provide that level of support and help. You don't always get a chance to do that, but you certainly get probably more chance to do that in palliative care than as a GP.
So you've said how and why you like the palliative side. What are the challenging parts of it where you've felt like this is really, really hard?
Yeah, I think so. I can only talk for myself because I know lots of palliative care doctors, and everyone approaches it differently and has their own coping mechanisms and so on. But for me, the challenging, so the clinical side of things has been relatively straightforward. It has its complexities, of course. Pain management can be really complex. People are complex and have social issues, sort of emotional issues, spiritual issues, physical issues, all happening at the same time. And so trying to kind of support patients in a holistic way can be really, that can be really challenging. It's one thing being able to know how to use morphine. And actually in palliative care, we probably have a fairly limited number of drugs. We don't have a whole BNF's worth of drugs that we use. We get used to using a sort of narrow range of drugs. So a lot of it becomes, I don't want to say standard or make it sound like it's straightforward, because it's not. It has its nuances and complexities, but you're dealing with a certain number of drugs really, which you can get used to. Maybe that's what I'm saying. But the complexity or the challenge is sort of, like I say, you're navigating highly emotional situations. You're dealing with not just the patient, but their relatives, their family, sometimes their children as well, and trying to not overstep the mark, not be too much, not be too little for them. Trying to get that balance, it can be really difficult. I can't remember if you asked me about my personal challenges, but I think it's there is a lot of sadness and grief, and being exposed to that all the time. That in itself, I think, can have a bit of an impact on you. For me, it's left me often sort of paranoid that I'm going to get sick, or like I worry about it a lot, about developing a cancer or developing some kind of chronic illness, and it's just on my mind, and I have to sort of pull it back and be like, come on, Richard, don't catastrophize this. And maybe that's just me, it's not palliative care, but that's what's been one of my challenges, is constantly seeing dying people and grief, and then sort of having to navigate my own emotions through all of that.
I suppose that's with a lot of doctors as well, when they like constantly see something and they're like, what if I get it? Well, and that thought process that, oh, my family will have to go through this,
Yeah. And I'm constantly fast forwarding because I know what it's like, and I've seen what it's like, and I constantly fast forward. Oh, this could happen and this could happen. But anyway, that's just maybe my brain. But that's been my personal challenge with palliative care. And I think also just getting it wrong, because there have been times when I've got things wrong, and maybe not so much a drug wrong, but said the wrong thing, and or sort of jumped too far too quickly with the conversations and caused upset, and you just don't want to do that. And that's been, especially in such a sacred time of life where you've only got one chance, sort of thing. So that's happened from time to time.
And how do you find do you find it challenging speaking to family members about when their loved ones are coming to the end of their life? I assume that's one of the most challenging parts.
There's a spectrum. It's perhaps easier for those older patients. I think as the patient gets younger, it seems to get harder. I think certainly, like some of the but that's not a rule in any sense, because everyone's so different, and you can have family members of a 90-year-old who's dying quite peacefully being extremely distressed. But it does seem, and I think particularly for the younger patients, particularly patients who are the same age as me, and then particularly patients who are now younger than me, as I get older, patients get younger, and I think finding the right words, speaking, trying to find hope in what seems really devastating and dark places where it feels like there is no hope. That's very difficult. Yeah, it takes its toll on me as a person, I would say. Which is why well-being is so important, stepping out and after these emotional conversations, debriefing with colleagues and just sort of stepping away from it, really.
And that communication, just as you've said, it's just such a huge part of it's a huge part of the work, and making sure you get it right. Just as you said, it's in such a precious period of that person's life, and it's, as you've said, such a huge privilege to be the doctor that you're in the care of that person. On the topic of palliative care, I know I've had some previous teachings with you, and often people can mischaracterize what they actually mean or what they think palliative care means.
Yes.
Sometimes, when you mention the word palliative care, it's only about, okay, the image in your mind is someone who's imminently dying, and they've got a complex series of medications going on and complex needs, but it's far more than that, isn't it?
There's something really important about definitions here, and I really do appreciate that the language gets confusing, and especially because we try and speak a particular language around palliative care in Dudley. If people come from different organisations, they've come with their not baggage, but their sort of idea of what palliative care means from where they've worked before. Also, we have things like Macmillan. Everyone thinks that the Macmillan team, they've seen the adverts, they've seen that we sit and have cups of tea with people and so on. That's what they assume that we're going to do. So not just from doctors, but from patients
as well.
There are assumptions all over the place. I mean, I think really the way that I think about it, and not just the way I think about it, the way we promote it across the Dudley economy, is that palliative care can either be core level or maybe generalist palliative care. That's the sort of palliative care that everyone does, whether you're an HCA, whether you're a consultant in vascular surgery, whatever you do, when we're looking after people in their final sort of end of life, so 12 months of life, and you're trying to improve a patient's symptoms, and you're doing palliative care. Specialist level palliative care, which is what I do, is when generalist teams are sort of, I don't really know what to do with this pain relief. I don't know what to do about this ethical situation. I need some support with this complex social situation. It's when the parent team needs some support. It's when they've reached the limit of what they can do. It's like, actually, I don't really know what to do now. I need some support here. And that's when the specialist palliative care team gets involved. We don't just see people who are dying because just because they're dying. We're not a sort of death and dying
Mm.
team. We're trying to be clear that palliative care is for everybody to do. Everybody needs to be trained up in it. Everyone's got a role in end of life care,
Wow.
meaning the last 12 months of your life, all the way down to the last days or hours. And then we come in if the generalist teams are struggling.
Mm. So someone who might, previously think, actually, palliative care, that's that team over there, they deal with that. I'm not really involved. But if you think of it, in that generalist palliative care, as you've
Yeah.
mentioned, if someone is in their last 12 months of life, it might be really difficult to, well, kind of predict that to start with. But if you don't kind of look back at patients that you've previously seen or treated, or that person who had reduced function to hold their cup, and you've had to help them with that, and you just think back to the people you've seen, and you can actually then think, actually, maybe I have been involved in palliative care and I just didn't know it. Mm.
Yes.
So that is interesting.
Yeah. And I think, patients who coming into hospital is almost by definition a poor prognostic factor, because studies show, not just here in Dudley, but other studies show, and we've shown it in Dudley, that it's something like a third of the patients that are in hospital today will die at some point in the next 12 months. So talking about, excluding peds and maternity, adult inpatients, a third of them will die in the next 12 months. So if you think about it, that's a lot of people who are in their in their end of life, in their last 12 months of life. And so if you think about it, then that means that we're all involved in
Palliative.
some sort of palliative care.
Oh.
And even if that's giving paracetamol for pain, even if that's having discussions about what's important for that person, there's a lot of sort of generalist core level palliative care that can be done. So, from our point of view, one of my jobs is to try and educate people and try and make sure everyone sort of realizes that, and also realizes what the specialist palliative care team does. And it's for those more complex cases because if we saw all of the dying people in the hospital, that's a huge number of people. We would be overwhelmed. We wouldn't be able to see the more complex ones.
Do you think there's like a lack of training in resident doctors to recognize that, well, this patient might need palliative input, or like we need to put this patient on end of life treatment?
When
do you
that
think-
specialist
yeah.
help is needed, recognizing now I need.
I don't know about lack of training. Certainly it's an educational issue, isn't it? I think because when you become, just thinking about foundation year doctors, when you start in the hospital, you're really dependent. You're sort of making your decisions, but you don't really make many decisions. You wait for your seniors to sort of guide you. So one of our areas or target areas is trying to make sure senior doctors and doctors who are here sort of long term are aware of what we do. But we're always going to have FY1s coming in, FY2s coming in, and that there's got to be a continual turnover of education for them. You could look back at the medical school training and question whether they're getting enough palliative care training to think these issues through. You could look there. But yes, is there a lack of training? I don't know about that, but I think one way or another there's a need for ongoing training for sure. But training's not just attending lectures and things, it's asking questions. It's through your interaction with the palliative care team. We try to do as much ad hoc teaching as we can. So if someone's got an issue, so if you came to me and said, "Oh, I'm not really sure what to do," I wouldn't just do it for you. I'd hopefully show you why and how and talk it through with you there and then to try and build your understanding of it.
It's active kind of learning and not just absorbing information, but participating and really having understanding.
And you've probably heard of the GSF in this hospital. So it's something that's been rolled out for a few years now. and it's a culture change, I would say. It was trying to make sure that all of the wards, that's our target, is that all of the adult wards are accredited. There's I'm not going to go into it here, but there's a process of things that you need to do to become accredited. And the idea is that you're essentially raising that awareness of palliative care, raising those basic core skills so that everyone realizes that palliative care is everyone's business if you're looking after people who are in their end of life.
Just, I think another kind of big part of palliative care is on the topic of DNACPRs and establishing that and putting it in place with patients that we clerk or admit, and knowing when it's appropriate, knowing kind of whose decision or who should be involved. Could you just talk briefly about approach to DNACPRs and putting that in?
Because there's a little bit of like misconception in the public that DNACPRs are given out like Skittles. So could you talk a little bit about why we use DNACPR in the hospitals and when?
Sure. Yeah. I mean, so DNACPR is a do not attempt cardiopulmonary resuscitation. And I think, the first thing to say is that for patients who've got terminal illnesses and who are progressively deteriorating, there will become a point for everybody when physiologically your body would not survive a resuscitation attempt when your heart naturally stops. Maybe that's the first thing to say, that point comes for everybody. It will come for me, it will come for you. The question is, have we recognized that point? Have we communicated that point? We all want to live forever. Well, say we all, you know what I mean? There's nobody really wants to, unless you're hugely suffering, but you know what I mean? In general, people don't want to die, and actually death becomes like a very distressing thing, because obviously we don't want to lose our loved ones either. So the idea of putting in a DNA CPR form becomes almost synonymous with, well, you're letting them die or you're giving up on them, perhaps. And that's not the case. I think maybe it would be good to use an example. If you were having cancer treatment, and chemotherapy is hugely toxic to your body, and if you are not strong enough to tolerate the chemotherapy, then the chemotherapy will do more harm than it does good and can potentially kill people if they don't have the strength and we call it the performance status to tolerate that treatment. So a decision has to be made that actually when a patient becomes too unwell, they're not going to have this treatment. Resuscitation is also a treatment. It involves tubes, it involves injections, it involves drugs, powerful drugs. Those drugs and all of those interventions can do more harm than good. And so trying to resuscitate somebody when they are already, when they've got no physiological reserve, their strength has gone, their illness has made them so frail, it doesn't make sense to give them that treatment. What makes much more sense is to do everything that we can to care for patients, recognize that they're too poorly to be resuscitated, aim to communicate that with families, with the patient, aim to keep them as comfortable as we can, and allow nature to take its course. Because nature is going to take its course, whether we like it or not. Our hearts are naturally going to stop. Now, there's a difference between, say, a 40-year-old man who's walking around and has a heart attack and falls to the ground suddenly. Actually, that's something reversible. And starting resuscitation, calling 999, trying to shock them if they've got a shockable rhythm makes absolute sense. But for someone who's got a terminal progressive illness, where we know that this cancer, heart failure, renal failure, whatever it is is going to bring this person to a natural end, then trying to restart the heart in that context won't be successful. And even if it is successful in that tiny percentage, it's not going to just bring people back to being
Full health,
well
yeah.
and walking around, and it's not going to do that. So I think maybe you asked about the approach. For me, when I talk about DNACPR, I don't talk about resuscitation. It's not my priority. My priority when I'm talking to patients who are in their end of life and perhaps coming into their final short months or short weeks of life, and I know that I need to have this conversation because they're following a predictable trajectory. My approach is to work out what's important to them. Now, if you work out what's important to a patient about when they do die, then I think I can do a lot more positive work. So let me just explain that. So I often say to patients something like, when you reach the end of your life, or you come to the end of your life, and we know that your heart is naturally going to stop, and I often use the word naturally because that is what's happening. Where do you want to be? Where do you want to be looked after? Now, we know from the numbers that over 70% of patients will want to be at home when they die. That will be their absolute preference. The figures are probably a bunch higher than that. But if I establish that that's where they want to be, I say, okay, so you want to be at home when you come to the end of your life, when your heart stops. Tell me what else is important to you. Oh, well, I'm scared of being in pain. I want to be comfortable. Okay. Who do you want to be with you? Oh, well, I want to have my family around me. So I almost help them paint this picture of what they do want. And then I talk about what we can do. So we've got these medicines that can help you. We can support your family. We've got these carers that can help you at home, look after you at home. We talk about all the positives. And when we've painted that picture about what we can do and what we will do to reassure them, then often they've sort of made their own decision. Because actually they don't want the tubes, and they don't want the tube down your throat. They don't want the chest compressions. They don't want those things. They want a nice, peaceful, comfortable, full of dignity death. So often my approach to talking about resuscitation is to not talk about it at all to start with. And then when I talk about a resuscitation decision, often it's because I'm saying this decision will support the things that we're trying to achieve for you. So I try and put it in the positive. Does that make sense?
Yeah.
So because DNACPR by inherently is, we're not going to give you this treatment. And often people feel like, well, I want you're denying me from having something. And what I try to do is help people see it in a positive.
Yeah.
How it's going to achieve something for them rather than take something away.
I think that's very important that like you ask them what you want rather than jumping into going, well, you're really poorly. Have you considered DNACPR? If your heart stopped. Because a lot of people start that conversation like, yes, you've come into the hospital. There's not much we can do. If your heart stops, do you want us to restart it or not? Yeah. But I think your approach to, look, you are unwell. What are your, wishes?
Priorities.
Like, what is your priority?
Priorities, yeah.
Because
and it puts the patient at the center.
Yeah, and also if you acknowledge this first, then it's easier to discharge them to where they want to be rather than waiting and then 1 week into the hospital say like, ooh, shall we discuss this now? And then it gets even harder to like discharge them properly.
Yeah. But it comes in steps though, because the first thing you have to do is, first of all, recognize that that person is that poorly. Because obviously it's not, DNACPR is not appropriate for everybody.
Yeah.
Some people are still having active treatment and so on. But for that subset of patients who are this poorly, do we as doctors and nurses and healthcare professionals, do we recognize it? And once we've recognized it, the patient's not necessarily going to recognize it, and the family's not necessarily going to recognize that they're this poorly. So we've got to have those sensitive conversations and talk about what's really happening. And there's, if there's anything that I've learned in medicine, over the years that I've done it is being transparent with patients and families, not holding things back. You know, when people are poorly, they sort of need to know. Obviously, you've got to temper that with what they want to know and what they don't, and you know that's a whole communication skills session. But in essence, you know, we're trying to be open and honest with patients in a gentle and sensitive way, because talking about these difficult things sooner rather than later gives people a chance to prepare, have conversations that they want to with their loved ones, plan for what they want to do next. Maybe they've written a will, maybe they haven't, but maybe they've got stuff they need to get done. You know, and if we're just beating around the bush, sort of not having conversations, then it doesn't help anyone. So it's recognizing is the first thing. Number two, it's then having the conversations. And then number three, it's making those plans. Well, what are we going to do next? Does that make sense?
Yeah.
Yeah.
I think it was very well summarized. Recognize, have the conversations, and then plans can be put in place.
Yeah. And I think one of the challenges that I see again and again is, in fact, if you look at the trust, and I think it's not just Dudley, but if you look at most trusts' complaints, the things that people complain about, most of all, it's communication. And not just about end of life, but about lots of things. But it's always about, almost always around communication. And I wasn't told that my loved one was going to die, or they told me in this way and we weren't ready for it, or whatever it is. But communication. So for me, I've learnt to be as transparent as I can and be proactive about my communication.
Yeah, I think you're right that if you just told them where this is going, they have time to absorb it and then tell you, well, this is what I want. Even like just, simple things like blood results and showing them like this is how it's going, so that they have an idea that, okay, I may not stand a chance.
Often patients know for themselves how, and the family who know at bedside who are observing, they can often tell you, this is, these were the things I was able to do, 4 weeks ago, then this is how it's changed, and
that's
they
right.
can see the.
That's a really important point. And I think in terms of talking about the future, people often want to know how long have I got left and what my prognosis is. And I think the way that I like to answer that question is with sympathy, or maybe empathy is the right word. This is a really difficult question for you to ask, or this must be hard for you to find the words to, or find the courage to ask me this question. But often I try and just put it back to them and say, will you tell me how things have been recently? And then they, like you say, Victor, they can say, oh, I was much better 4 weeks ago than I am today. And how long do you think you've got left to live? I mean, I'm just telling you in summary here, but it's along those lines. How long do you think you've got left? And I usually put it back to them, and then they tell me, and they're often right, because I think patients often have clocked it and they figured it out. It's just that no one really wants to hear it from the doctor, because when you hear it from me, then it solidifies, it makes it much more real, and that's hard to have to deal with, I think. But so I often just put it back to them. What are you thinking? And they'll say, "Oh, I think I've got a couple of months." I'll be like, "Yeah, I think you might be right." Obviously, if they're wildly off and they say, "Oh, I've got another year left to live," then I find there's a mismatch then, and now I've got to use communication to try and bring us back onto both onto the same page again.
Yeah.
So but communication is really important. But I don't know, going back to the DNACPR thing, whether that's helpful. But I think just sort of trying to talk about it in a more positive, like flipping it round. It's like, think about all these things we can do for you now. My job is not to take away patients' hope. It's to maybe change what they are hoping for, what's sort of possible.
That's a good way to look at it.
Yeah. I think we've covered extensive number of topics, and again, as usual, I'm sure there are so many points that people can take away from there. I think this topic not only for our healthcare staff, not only the resident doctors and allied health professionals, but even patients listening. They'll have a deeper understanding of what palliative care involves and how it can be viewed. So thank you so much
No
for
problem. Thank you for having me.
for coming back and shedding some light on this area of medicine, and I'm sure it's going to be appreciated by
Oh,
so
thank
many.
you. Thank you.
So we appreciate that. Thank you guys for sticking with us all through the podcast. I'm sure there is lots for you to take with you. As usual, if you have any questions, feel free to message or post a comment. Also, we'll be putting some polls up as well, so feel free to interact with those and engage with us. Let us know what you would like to see, what you like to hear. If you want to be on the podcast, let us know, and we'll be sure to get back to you. So that's on all our platforms: YouTube, Spotify, Vimeo, and the rest. You will find on RUGC. Once again, that is from me, Victor, and
Jaspreet and
Jaspreet
Richard.
and Richard. So thank you all, and we'll see you next time. Remember to stay connected with us on social media. Follow us on Instagram and TikTok at RGUCMS, and subscribe to our YouTube channel, RGUC Media, for more exclusive content and updates. Thanks for tuning in to the Right Chamber podcast. Until next time.